I'm Seth, the training manager with Incorporate Massage. Today I'll be teaching you how to treat cubital tunnel syndrome. All right, so let's say that you've already done the work for thoracic outlet syndrome and you've done the work for carpal tunnel syndrome, but the client is still complaining of pain that starts at the elbow and goes along the inner line here towards the pinky and the ring finger. That's a good indicator of cubital tunnel syndrome, which usually occurs when the ulnar nerve is being compressed or there's direct restriction upon it. So you've already checked the entire rotator cuff for referral pain from trigger points, making sure that it's not mimicking that pain right through here. So once you've eliminated that factor, you'll go into direct treatment. So what we'll do is we'll start up towards the attachment of the tricep right here. And we're going to palpate, find that medial border of the attachment, and then we're going to hook with these three fingers, making sure that the most pressure is going through the middle finger, but we're not going to push in. And once again, if you feel a pulse, reposition. But we're going to make contact here first, ring finger second, pinky finger third. And we're just going to hold it there. And then you can either sink down or back, or if you're in a chair, you can pull straight across. And you're just going to glide down nice and slow. So note, we're going to be doing this in 3 different positions. With the arm. The closer you get to the elbow, you might feel more fascial adhesions. If you do, change your trajectory, the pressure, or the speed at which you're gliding to allow the client to feel more comfortable. And you can go through after that. Just do some compressions. Okay, and then we're going to place the elbow back on the pad here, and we want to bring the elbow into flexion, and then we're going to either radially or ulnarly deviate the wrist and do a little internal and external rotation. So it helps do a little flexion at the wrist also. And if they can't handle this much, just either don't do as big of a range of motion or don't do it and just flex at the elbow. So we're going to start up here again, flexion at the wrist, and I'm just going to deviate in like that. I'm going to go back to that belly, and as I rotate internally, I'm going to compress and then pull back like that. As I get closer to the elbow, and here I can feel some of those adhesions, I'm going to change my pressure and its directional force and go a little bit slower. This is just basically a modified C grip where it's these fingers compressing and then I'm compressing it towards my thumb pad here. I'm going to go external rotation with the wrist flexion. Okay. Now, I'm almost going to put them in a wrist lock here, and I'm just going to rotate externally like that and deviate ulnarly. Is that right on your wrist there? Is that okay on your wrist? Mm-hmm. Okay. You can change the rotation with your compression. Kind of find a good rhythm and a glide and a groove and just kind of go back and forth and test it. Okay. Now, for the rest of it, we're looking at this area right through here. We're going to do almost the same thing. So we're going to palpate. There we go. Go a little out from there. Feel for the muscles right through there. Can you feel that in there? Mm-hmm. Okay. And then we're going to do the same wrist motion. A little bit of flexion. then here, I'm feeling for the ulna, the blade of it right there. I'm going right past it, kind of tucking my fingers in, and then rotating it like that. Now, if you get to a trigger point, or if there's any referral pattern, don't do the range of motion yet. Just keep straight wristed, and then use your pressure application for this. I prefer 8 to 12 seconds with a good maybe 3 to 4 on a pain scale of 1 to 10. But if your client doesn't want to talk and they just want to get the service, try to read them. If they're cringing or holding their breath, you're probably doing too much. If they start to shake their hand out, it means you're doing way too much or you're right on the nerve. Okay. And so we can do a similar thing as we did up with the tricep here, starting right through here. And you can either do it hanging out in the middle of the air. I prefer to have their elbow on a surface. And we're just going to kind of take these 3 fingers again, curl them in, and glide on down. Now note for body mechanics, since we're working at kind of a rotational torque right through here and we're gliding at a diagonal, for your body mechanics, what you'll want to do is you have your mid-sagittal line here, aim it towards your starting point, and I like to try to draw my fingers straight back towards my mid-sagittal line, keeping my elbow tucked in, shoulders back and down. Eventually, you can add a little bit of rotation, a little pronation through there as you do this. You can either add some flexion or extension to increase the tautness of the muscle as you work through. Make sure you work towards that, though, if you're going to do some pressure while it's taut. Then once again, you can go into our carpal tunnel routine where we do the push and pull mechanics. Go back and forth. And if there's a lot of restriction, and you notice upon palpation that the antagonists for these groups, like right through here, right through there, are very tight, and maybe they're also tight and weak, then you'll want to treat these also. You can do almost the same movements, but the trigger point manifestations will be a little bit different. One key one that you want to look out for is the Coracobrachialis. And so from here, we'll show that initial tricep glide from a different angle. All right, so we're going to follow the line of the posterior deltoid to find that rear axis there. Okay, and I'm just going to tuck underneath it, those 3 fingers. We're just going to glide down. Work a different head of the tricep. Right through there. Can you feel that, Russ? Mm-hmm. There we go. So, just a little Sethler nugget of information here, as my friends so affectionately call it. The way I was taught to use the hand, these 3 fingers right here for tool manipulation, okay? The inner line of the ring finger is for aim or direction, rotational axis, and the pinky is for counterbalance, okay? That's why there's not a whole lot of power that goes through it, okay? And so if you take someone who does a lot through here, let's say that they're working at a desk and their elbows are planted and their wrists are deviated, this entire line through here is imbalanced. This one's overworked. And that's what leads to a lot of the cubital tunnel syndrome. You see it all the time. People be like this at their desk typing, grabbing something, drinking it, what have you. And so oftentimes you will have to include the antagonists, but if you imagine that you were throwing a punch, you would aim through this point right here with a straight wrist, and you'd make contact anywhere through here, okay? And that's just a straight wrist punch. Most people don't have a straight wrist while they're working at their desk, okay? Unless they're at a standing desk, it's a little bit easier just for upper body postural mechanics. And so if you visualize as you're working on people or doing a postural assessment where their resting wrist location is, or how their elbows are, their shoulders are internally rotated, what have you, it'll give you kind of a good gut feeling about what you might want to work. Because once again, this is just a piecemeal, a tiny piece of the puzzle for the 10 to 15 minutes you might have with someone on a chair. And so if you do all this work and you see that torque right through there, maybe a little bit of malformation through here or right in there with a bone structure, like your gut may say, hey, I'm going to hit the cubital tunnel there. And you just go in there. A little bit of the carpal tunnel. You come up in here. Right like that. And if you'll notice, I always do a push and pull movement, rotating on a certain axis. Once again, if you were to have a light fist, if you want to make a little fist for me here, with a straight wrist, if he were to aim his pressure right through here, kind of push straight into me, can you feel that engage back into your subscap? Okay. Equal distribution of force. Okay. If he were to go off just a little bit, like with that deviation right there, and then push through that point, you feel the difference there?
Yeah, it's not in the subscap anymore.
Yeah, it changes what muscles are recruiting and engaging. And without that subscap engagement, that pressure that he's pushing won't go to a center of mass or gravity, and it won't diffuse evenly through the rest of the body. So if you kind of think in mind or in frame of that, like what muscles are engaging, what should I work on, what's contributing to this, and then just kind of spot fix it and go through it, you'll get better at gut reading how to most effectively treat your chair clients with the limited amount of time that you have. This is Seth from Incorporate Massage. I really appreciate the time that you've spent with us today. I encourage you to look at the additional training videos that I mentioned prior, the thoracic outlet with Brooke, and then the one that we did on carpal tunnel syndrome. As you take those pieces together, you can recombine them into a whole unit and really serve and empower the people that you work on. Make it a great week.